I'm just going to talk a little bit about a subject that's dear to my heart. We've been working in this area for around 8 years, really with the help of a large group of people across Australia and New Zealand. So many of you from your hospitals would have contributed data to some of the work that I'm presenting, and also the ANZIC's clinical trials group has been integral. In the clinical trials group, one of the main studies that's been running for the last 8 or so years is the POLAR study, which is a study of hypothermia for traumatic brain injury. But we've been looking at a different area, so that maybe once the POLAR study is finished, we could ask a different question about temperature management. And the thing that's interested me is this idea about avoiding pyrexia, because it seemed to me when we started that actually this was a more prevalent problem in the patient population that we treat. The definition of what is fever and the management of fever, if it is a problem, how do you do it? It's a very difficult entity to treat, and does it make a difference to the outcome of the patient with TBI? And it's a lofty ambition to try and take this forward into a phase 3 clinical trial that might change practice, but we've just done little bits of work over the last 8 to 10 years to try and fit bits of the jigsaw together so that we can perhaps make the case to explore this. So I'll just go through some of that over the next 15 or so minutes so that we can finish in time for lunch. Okay. Now, I like putting these slides up because they're historical ones and about the concept. I don't know, how many of you came last year? How many of you were here last year? Okay, so not too many, so we've got a new bunch, so it's okay that I'm repeating these slides. Good. This is Temple Fay. He's probably the forefather of using temperature modification to try and treat pathological conditions in humans. He was actually interested in surgical oncology, and he was an innovator. So in the kind of 40s, 50s and 60s, what he did was he rationalized, he thought that reducing temperature could be a form of treatment for cancer, wherever it was occurring, whether it be localized in the brain or systemic metastases, because he noticed that changing temperature around a cancerous lesion reduced the volume of it, and perhaps caused an analgesic effect for patients who had refractory pain symptoms. And that's how he started. And it's just worth looking at how he did start. So this is back in the 50s and 60s. He modified a CO2 canister, would implant these into brain. So this is next to a neuroblastoma that was causing a lot of pain for the patient involved. And these would be connected externally to water circulating at cold temperatures. He'd use this for up to 10 days as part of treatment for various syndromes related to cancer. And here's a picture of one of his first patients. It's great, isn't it? This is the 1950s, and this guy's having a cigarette while he's being cooled and treated for his neuroblastoma, potentially. Here's a doctor who had disseminated malignancy through his thorax and abdomen, who had refractory pain, and there were no chemotherapeutic agents or surgery available, but he covered this guy in ice and noticed that you got some temporary relief from pain and swelling. And this is probably the first cooling blanket. You can see, I think this patient is not intubated, or I can't tell. But this is probably the first cooling blanket. Again, late 1950s and 60s. And it wasn't to the end of his case series of about 150 patients that he began to think, well, maybe this is useful for conditions such as trauma to the brain, where there's swelling, and perhaps you can reduce the swelling and treat head injury by this method. And that was the start of our interest in it as a treatment for head injury. But one of the things I think is worth, the historical slides are interesting, but we've come a very long way because we've moved, as you've seen with the technology that we have. We're still arguing about what the target is, what the depth is, how long we should do it for, how fast we should do it for, but we do have much better technology that allows us to precisely deliver the treatment that we want, or the dose that we want. So that's available to us, and as Andrew has said, we have neuromonitoring, and I think even though we may not have found the target or the depth, we now have the ability to look much more scientifically at what we're doing and perhaps get to some of the answers. And I think it's just worth contrasting between what we did have and what we have now. There's been a huge amount of progress. And so this is a temperature chart of a patient. I've got rid of all the other vital signs. You can see it varies a lot, and the patient's probably getting paracetamol and intermittently some physical cooling. The reason I put this up is I think the fever responses are really strong, innate. It's something that's inside of us, that's been with us for a very long time, and it may be the body's way of repairing injury. Maybe it's the best way that we have to repair injury, because it's very difficult to treat fever, even if we want to, particularly in the neurological patient. But we can do that. The question is, how do we do it to an individual patient to improve their outcome? And this is Chloe, who survived a very bad brain injury. She looks like she's had a great outcome. She lives at home now. She does drive around, but she's very different to the person that she was before she had the injury. She probably, before the injury, would have swum for Australia at the Olympics and gone to university. But after the injury, although she's able to get home, she can't complete university because she lacks the processing skills to do that. And she's had to drop out, and she'll probably be a swimming coach, I think. She has a very attentive mother who's helped her through the last 4 or 5 years, who was a swimming coach, and I think she will reinvent herself at that role. But she's a very different person to who she was. And I just wonder, which temperature curve would have been better for her? The one with the bouncing fever, where the brain is actually allowed to repair, the innate response is not fiddled with, or the one where we flatten out the temperature and we control it very carefully, reduce that variation. Is that better? I don't think we know. I don't have the answers, but I'm just going to present some work to you about what we've done in this area and just leave you with, I think, some thoughts around that. So I talked a little bit about how reducing temperature might help. So it might reduce swelling. I think that's one thing it may do. It probably does reduce metabolic rate. I think we're quite clear. So it reduces the need for nutrient delivery to cells that are injured. And I think by reducing tissue edema, what it does is potentially increases flow to the brain because it's in a confined space. So you could argue that reducing temperature has an anti-ischemic effect overall. It also clearly, from animal models, seems to affect inflammation and modulate it. And in animal models as well, we have some evidence that it improves histopathology and neurobehavioral outcome of animals. And Max is going to talk a little bit more about the animal models. I'm going to leave you with the thought that the animal models are compelling, but I think he may provide a different perspective for you. But there's certainly a lot of data from animal models that makes us want to investigate this in humans. The problem that we have is that when we have investigated reducing temperature in humans, particularly traumatic brain injury, cardiac arrest, these things, and in parentheses are the numbers of clinical trials that you can find, there doesn't seem to be an overwhelming effect. Certainly in the perinatal birth asphyxia region, there may be a benefit, but in all of the others, there seems to be either a neutral effect of reducing temperature into the hypothermic range, or maybe a harmful effect. And that kind of led us, when we were looking at patients in our unit who were getting fever, to think, well, maybe just reducing fever and treating fever is a more gentle approach that avoids the side effects associated with being more aggressive and taking people down into the hypothermic range, but might provide the benefit. And there's probably a curve of benefit versus risk when you reduce temperature. It's just we've got to find where it is. And so we thought we would look at avoiding pyrexia as a potential intervention. So what did we do? We've done 3 main things over the last 7 or 8 years. One thing is we thought we should describe what happens across Australia and New Zealand. I think I know what I do in my clinical practice. I have some kind of idea what my colleagues do within the unit, but I'm not entirely sure because we all argue, we all differ in our perspectives. I don't know what other hospitals do in New South Wales or across Australia and New Zealand, but if we measured it, we would get some impression of what we were doing as a group within the region, and maybe that would allow us to plan a clinical trial that might answer an important question. So one of the things we thought we should do is we should measure it. So that's one of the bits of data I'll present to you. The other thing was we had options through two databases that we had to explore the association between temperature early after traumatic injury and stroke and look at longer term outcome to see whether there was a relationship. So again, using Australia and New Zealand data to generate hypotheses. And the other thing, we knew that paracetamol was very commonly used as an intervention in Australia and New Zealand, not non-steroidals that are used in other areas of the world. We thought, well, let's do a little clinical trial to try and find out how effective paracetamol is actually at reducing temperature in this patient population. So those are the three bits of data. And look, although we would love to do a clinical trial, I'm not sure how feasible that is given the heterogeneity that we've talked about. But if at least we do this work, we can think about proceeding in that way. So when we measured clinical practice, what we did three actually observational studies. I'm just going to present you the data from one of them, which was the last one which we did. And this is a prospective study where we had 16 of the 21 intensive care units that manage neurosurgical patients in Australia and New Zealand participating. So 3/4 of the units. And for a 6-month period, we looked at every patient who was admitted with a TBI and stroke who was expected to stay at least 3 days. And what we did was we looked at what their temperature curves were. And this essentially shows a graph of the proportion of hours per day on average spent above certain thresholds. And you can see the first thing is that almost all of each day is spent above 36 degrees Celsius, meaning that we're not great users of hypothermia. So that's what I would take away from that. But depending on where you decide to define fever as, 37, 37.5, 38, you can see it's anywhere between 15 or 16 hours a day to between 4 and say 7 hours a day above 38 degrees Celsius. So this is standard practice. I'm not sure what the definition of fever is. I don't know what it is. I don't think we can tell, but at least we have a sense of the proportion of time that our patients are spending above these various temperature thresholds. And this is under the experience of normal treatment, which is paracetamol and physical cooling. So how were they used? Well, in our study, we found paracetamol was used. It was used commonly. Almost 95% of patients got paracetamol. The first time it was used was on average 15 hours after admission, and the temperature that it was used at was 37.5 on average. And you can see physical cooling is used in a more delayed fashion in this patient population of TBI and stroke. It's used roughly 2.5 days after patients are admitted, and it's used first when the temperature hits 38 degrees Celsius, or in 1/4 of the patients you can see the ICP is elevated. And the interesting thing is when it's used, the temperature is maintained roughly between 37 and 38 degrees Celsius. So it's almost like we're using pharmacological and physical agents in Australia and New Zealand, slowly, incrementally introducing them to keep temperature in the range between 37 and maybe 38 degrees Celsius. And why should that be? Well, I think what we're describing is a stepwise approach, which is very reasonable, rather than a prophylactic, preventative approach. If you used 37 as your trigger for fever, if that's what you wanted to do. I think it's partly because we don't have great data on whether reducing temperature is beneficial for patients, and maybe that's some of the hesitancy. And there is risk associated with modifying temperature, both in terms of your need for sedation and countering of shivering. And the other thing is we always want to assess our patients. So if we want to assess them neurologically, we have to reduce sedation, and it's hard to use physical cooling when you're reducing sedation. I think that's all understandable. So we have some understanding of where we are in Australia and New Zealand. Globally, we don't really have a sense of where we're at. We know that non-steroidals are used in other jurisdictions, but we don't know a great deal about the detailed information that we have from Australia and New Zealand. Just in the interest of time, I'll skip one of the cohort studies and just present the second one. We'll go here. So this is a cohort study looking at the relationship between early temperature and outcome. And if you look at the top two panels, this is large numbers of patients from Australia, New Zealand and the UK. You can see these lovely U-shaped curves for TBI and hemorrhagic stroke, so subarachnoid hemorrhage and intracerebral hemorrhage. So you'll normally find a U-shaped curve for any biological parameter, whether it be blood pressure, heart rate, glucose, cholesterol. It will be high risk of mortality at very low levels and high risk of mortality at very high levels. But you can see here there's a reduced, or the minimal risk of death seems to occur between 37 and 38.5 degrees Celsius for patients with traumatic head injury or hemorrhagic strokes, which is the majority of the patients. So something about 37 to 38.5, which isn't dissimilar to the practice that we've described in Australia and New Zealand. And it's probably under conditions of the use of paracetamol and physical cooling, as we've already described. The bottom graphs are interesting because we thought we'd look at neurological infection as a different pathology to trauma or vascular insult. And you can see you lose the higher inflection point there, perhaps suggesting that fever might be beneficial for infective illnesses. That's a hypothesis that we could explore. Paul will talk a little bit more about this later. But the main reason for doing this kind of study was to look at where the minimal risk was for patients with traumatic brain injury and stroke. What I should say about the data that I've presented already, both the observational study, the nice temperature graphs and these temperature graphs, is that although we've lumped TBI and hemorrhagic strokes together, when you look at those groups independently, the graphs are the same. They're very similar. You have a bit more fever with subarachnoid hemorrhage, but the graphs are essentially the same. Okay, so finally, just to finish, the last bit of data we did was a small clinical trial looking at how effective paracetamol was as a prophylactic prophylactic antipyretic. So we compared paracetamol versus placebo in patients with traumatic head injury. Now our study was powered to look at a difference of 0.5 degrees Celsius. We didn't find that. The average difference between the two groups was 0.3, and this is not a statistically significant result. But you can see there appears to be, over time, a lower temperature by about 0.3 degrees Celsius consistently between the two groups. Two confounders in this study. So phenytoin causes the rapid metabolization of paracetamol, and that was administered in a high proportion of both groups. So maybe that's interfered with the paracetamol effect and reduced it. And the other thing is that the paracetamol group also got slightly more physical cooling than the placebo group. So it's possible that paracetamol has an effect, but even if it does have an effect, it's relatively small. It's of the order of half a degree, maybe a little bit more, but it's not going to be great. But even if you give regular paracetamol, you're not getting temperature below 37 degrees Celsius. It's well above that threshold. So this was published in PLOS just a couple of years ago. So what do we conclude? I think these are the conclusions I would leave you with. Max will explore a little bit more about animal models and TBI and how they relate to clinical medicine, but I think there is a rationale perhaps from animal models that reducing temperature may be beneficial. The cohort studies, as I've suggested, suggest that temperature in the range 36 to 38.5 is probably associated with least risk, but there is probably the problem of residual confounding in observational studies, but they're there to perhaps generate hypotheses. Paracetamol at best has a modest effect, and in Australia and New Zealand, on average, we use paracetamol and physical cooling incrementally in a stepwise approach rather than a preventative approach to preventing pyrexia. And we still have this question of, is a clinical trial feasible? And we'll sort that out once the POLAR study is published. Andrew's mentioned this nice feasibility study that we're doing at 3 sites. We're about just under a third of the way through recruitment of this study, and the really interesting thing is that we'll get information on how different temperature strategies affects neurobiology, and that's really important for understanding mechanistically what reducing temperature is actually doing to the injured brain, and that will also help us decide what to do next. I'd just like to acknowledge all the funding agencies that have helped with the work, and also the ANZICS Clinical Trials Group who have been instrumental in that work. Okay, so that's all I had to say. It doesn't really provide you with answers of what you should do if you've got a patient with fever. I think at least you know what people are doing in Australia. You know what paracetamol does. You can make an informed choice as to what you want to do, and maybe one day we'll have high quality data to inform us. Thank you very much for your time.